I was basically going through their data sets and trying to help the executive team see where there were gaps in care variation. And I remember presenting findings to the chief medical officer at the time, and they were so proud about, reducing readmissions for a particular condition. And I remember having to burst that bubble, and I said, well, actually, it didn't happen because of A, B, and C. And I remember the executive at the time saying, well, no, the numbers must be wrong. And it kind of triggered off this whole process of kind of going through and walking through and explaining why that was the case and what were the other variables and factors that could explain the changes in outcomes. And it wasn't just about the numbers. There needed to be context from a policy point of view or how the physicians were reacting to a protocol. And so I think it's a long-winded way of saying I saw this kind of gap in kind of how to bridge the data to then kind of apply it to the next step in a, whatever was the hospital policy or a new procedure for the physicians to implement at the bedside. And it was so apparent that there was a lack of policy understanding in some regards. And then those who understood the policy very well maybe weren't as in touch with what the clinicians were struggling with at the front line. And so I think I saw all these great ideas and this great direction of where healthcare needs to go, but I could see why it was moving so slowly because there wasn't a lot of intersection and collaboration between these entities, whether it was the academics with the practitioners or just within the practitioners, the different segments of the industry. And so I think I came out of that with a pretty strong viewpoint that I don't believe in the term best practices.